Hello there, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. We shall today discuss the pathophysiology of traumatic brain injury. In the end, please subscribe to our channel and give us a like if you find the lesson useful. So let us not waste time anymore and start right now. Traumatic brain injuries result from a violent collision, acceleration, deceleration, and rotational movement of the brain. It accounts for approximately 1/3 of all trauma-related mortality. Road traffic accidents are the most common cause of head and brain injuries. Other common causes are falls and assault. A traumatic brain injury causes brain damage via primary and secondary mechanisms. The primary injury is sustained on impact, and the secondary injury develops in the following hours and days. The primary injury results in local tissue damage from the initial impact, such as intracranial hematomas, skull fractures, lacerations, contusions, and penetrating wounds. Energy transmitted to the skull and the underlying brain tissue can cause direct injury at the area of impact, known as coup injury, as well as on the contralateral side, known as counter-coup injury. The secondary injury is an inflammatory response resulting from hypoxia, hypotension, intracranial hypertension, thrombosis, disruption of the blood-brain barrier, leukocyte infiltration, and release of immune mediators including chemotactic factors and cytokines, all resulting in brain edema and neuronal damage. One of the basic goals of critical care medicine and neurosurgical intervention in traumatic brain injuries is to minimize the effects of the secondary injury. The head injury may result in skull fractures, parenchymal injury, and vascular injury in any combination. The anatomic location of the lesion and the limited capacity of the brain for functional repair and tissue regeneration are the major factors that decide the consequences of a head injury. The survival of the brain depends on the continuous delivery of oxygen and glucose through the blood flow to the brain. Normal cerebral flow is about 55 milliliters per minute per 100 grams of brain tissue. A drop in cerebral blood flow below 20 ml per minute per 100 grams of brain tissue results in cerebral ischemia. Lower than this level will result in infarction due to neuronal death unless promptly corrected. The traumatized brain develops inflammation and edema that can be worsened by ischemia. Cerebral blood flow depends on cerebral perfusion pressure, which is the difference between mean arterial pressure and intracranial pressure. Typical normal cerebral perfusion pressure, mean arterial pressure, and intracranial pressure values are 75 to 105 mm Hg, 90 to 110 mm Hg, and 5 to 15 mm Hg respectively. In normal individuals, mechanisms like CO2 reactivity and cerebrovascular autoregulation maintain a constant cerebral blood flow across a range of mean arterial pressure between 50 and 150 mm Hg or higher if there is a chronic systemic hypertension, and therefore a matching range of cerebral perfusion pressure. Cerebrovascular CO2 reactivity refers to the cerebrovascular constriction or dilatation in response to hypo or hypercapnia respectively. This is a stronger mechanism as compared to cerebral blood flow autoregulation. Monro-Kellie Doctrine. Alexander Monro in 1783 hypothesized that the sum of volumes of brain parenchyma, cerebrospinal fluid, and intracerebral blood is constant. An increase in one will cause a reciprocal decrease in either one or both of the remaining two. The reason he put forward was that The cranium is like a rigid box containing a nearly incompressible brain, and therefore the blood volume inside the skull should remain stable in normal as well as in pathological conditions. Whenever the contents of brain expand, such as due to hematoma and swelling, initially there is a reduction in fluid components that are blood and cerebrospinal fluid, and any further expansion will cause an exponential rise in intracranial pressure. Thus, Monro-Kellie Doctrine describes a relationship between intracranial contents and the intracranial pressure. It has remained a fundamental concept for over 200 years in neurology and neurosurgery. Cerebral herniation. A cerebral herniation occurs when brain tissue, blood, and cerebrospinal fluid shift from their normal position inside the skull due to an uncontrolled rise in intracranial pressure. The condition is usually caused by brain swelling from a head injury, a stroke, bleeding, or brain tumor. A brain herniation is a medical emergency. It is often fatal if not treated promptly. Cerebral herniation has been classified into four main categories: subfalcine, transtentorial, central, and tonsillar. The tentorium is a sheet of dura mater that separates the cerebellum from the cerebrum. The transtentorial type can be further subdivided into two types: descending transtentorial or uncal and ascending transtentorial herniations. In subfalcine herniation, the ipsilateral cingulate gyrus moves beneath the falx cerebri. The brain tissue is pushed across the other side, often described as a midline shift. This is the most common type of brain herniation. In descending transtentorial or uncal herniation, the innermost part of the temporal lobes, known as the uncus, is pressed over the edge of the tentorium, entrapping the ipsilateral third nerve, causing pupil abnormalities and directly compressing the midbrain. It usually occurs in rapidly expanding traumatic intracranial hematomas. This herniation is the second most common type of brain herniation after the subhype. In ascending transtentorial herniation, the cerebellum and the brain stem move upward through the tentorium cerebelli. In central herniation, the diencephalon and parts of both temporal lobes herniate through the tentorial notch because of bilateral mass effects or diffuse brain edema. In tonsillar herniation, increased pressure in the posterior fossa forces the cerebellar tonsils to move through the foramen magnum. This compresses the medullary vasomotor and respiratory centers, resulting in Cushing's reflex, producing the classical Cushing's triad of hypertension, bradycardia, and chain stop breathing or irregular respiration. The main clinical features are severe headache, head tilt, and neck stiffness due to tonsillar compression. This condition is also known as coning and may result in death if not treated right away.